Good evening and a very warm welcome to today's webinar. Uh, so, the topic for today's webinar will be clinical impact for NGS, clinical impact of NGS for lower respiratory tract infection. I am Dr. Koyel Ghosh. I work in HaystackAnalytics as an medical science liaison, and I will be moderating the session for today's webinar. Uh, Thank you for everyone for joining, and warm welcome to everybody. So, first of all, I'll tell you about our company a bit. So, what is Haystack Analytics? Haystack Analytics, uh, sorry. So, Haystack Analytics is actually a a IIT-based company, a health tech company that was built in clinical genomics, that was building clinical genomic solutions for accurate, personalized diagnostics. This company was found in 2018 and it began in 2020 by validating TB genomics with different hospitals. In 2021, the Haystack Analytics launched a whole new genome-based TB drug-resistant test with 4 national lab chains, becoming one of the first growing genomic tests. The company also developed a genomic analysis platform, which removed the need for large bioinformatic teams and enables rapid clinical reporting. In 2023, it completed a multicentric clinical trials for an whole new area which is called the infection test, and the infection universal infection NGS was introduced, and which is world's first near point of care clinical genomic test. Haystack has received lot of support from lot of government bodies like DST, DBT, Intel, and also some private companies like GE, and collaborates with a leading institutions like IIT, AIMS, Harvard Medical School, and Tata Memorial. So with this, I would like to introduce today's speaker. Uh, and our today's speaker is Dr. Shamim Akhtar. Dr. Shamim Akhtar has been Dr. It's my honor to introduce him. Dr. Shamim Akhtar has been the head of the Department of Pulmonology at St. Stephen's Hospital, New Delhi. Dr. Akhtar is an accomplished pulmonologist with over 18 years of experience in respiratory medicine. He has been established in the Department of Respiratory Medicine at St. Stephen's Hospital and developed advanced facilities like bronchoscopy suits, sleep lab, and e-bus system. He has published numerous research papers and contributed to postgraduate training, as he is a recognized speaker in national and international forums like ERA, SNAPCon, Respicon, to name a few. We are very privileged to have him with us today. A great honor. And a warm welcome to Dr. Shamim Akhtar. Sir, over to you.
A very good evening to all the delegates, all the participants, friends, colleagues. And at the outset, I would like to thank Dr. Koyel Ghosh and Mr. Vivek Rathor for inviting me to talk on this very relevant topic. So, first and foremost, my greetings to all of you, and thanks for organizing this webinar this evening. So, let me start with the word haystack. So you see, it's very interesting when I uh, try to find out as to why the company has put a name like Haystack. We all know the meaning of haystack. You know, it's a pile of hay. मतलब एक भूसी का ढेर. So why at all the company would have thought to put a name like Haystack Analytics? And it's actually very interesting and fascinating to know that it's a metaphor. Haystack is a metaphor for the it's actually a complex genomic data. It's a large genomic pool from where like you are trying to find out a needle from a haystack. Like you have a large, huge genomic data ranging from few kbps to mbps data, and you're trying to figure out which organism or which genome is actually causing that particular disease or particular infection. It is just sort of, you may say that it is similar to something like we are trying to find out, we are doing it for cancers and malignancy for quite few years now. So it's very interesting to find out, and you have got a whole bunch of genome sequences, and you are using certain technologies, tools, which is actually a bioinformatic tool in today's time. And with the help of that, in a single go, you are trying to figure out actually to which organism just this particular genome belongs to, whether it is a bacteria, it is a fungi, or it is a virus. And then at the same time, you are also trying to figure out whether this bacteria, fungi is also mounting a gene which is responsible for resistance to a particular antibiotic or not. So it's very fascinating and very interesting, because majority of the tests which are available, even the molecular tests which are available with us, they are actually either for a bacteria or for a virus. Sometimes they can combine bacteria and virus, but combining all the organism together, it's not that easy. So with this background, let us take you to epidemiology of infections, why it is very much pertinent in today's time to diagnose infection at the outset or at an early stage. You see huge burden of infection, 49 million infections annually, 11 million deaths annually, and this is precisely a data from US. 4.95 million deaths due to drug resistance, and attributing to 30% of all deaths in ICU. And you see, these are all publications from a reputed journal ranging from Lancet to infection and chemotherapy to infectious diseases. So these are all authentic data, and these are from US. And you see, country like India, where there is so much of underreporting, you can anticipate that how much burden our country is bearing because of infections. So global burden of lower respiratory infection, it is the fifth leading cause of mortality, causing 2.6 million deaths annually. This is a WHO data from 2021, and out of which community-acquired pneumonia was the most common one, the major culprit for 3 million deaths annually. And the estimated mortality rate for hospital-acquired pneumonia was even more, so 20 to 30% for HAP, and going up to 50% for ventilator associated pneumonia. And you see, these data majorly they are from developed countries. And if you attribute this data to India, the burden may be much higher. So pneumonia contributes to 17.5% deaths in age group under 5. So you see, it's not only a disease of elderly across the ages, but more remarkable in underage, below 5 years, and above 50 years of age. So now you see, whether treating infection is a real challenge. We have so many of antibiotics in our armamentarium, but still remains a real challenge. Because for bad bugs, we all know about, we all are practicing physicians, and we all are aware about these deadly or notorious pathogens which are called escape pathogens, ESKAPE, escape, because majority of them, they escape the effect of antibacterial agents. And which are these organisms? These are Enterococcus faecium, Staph aureus, Klebsiella pneumoniae, Acinetobacter, Pseudomonas, and Enterobacter. So these mother, father, brother, and sisters and their kids in the block, they are very, very dangerous, and we have to tackle them. So to address these issues, IDSA sat in 2010, and they made a policy that we will develop 10 new antibiotics over the next 10 years. So this was called 10 into 20 initiative. So they thought that let us develop, because majority of the antibiotics are now getting catching resistance. So they came up with an idea, 10 into 20 initiative. So started in 2010, that we will develop 10 more new antibiotics by 2020. Although several new antibiotics have been developed, but that's all almost like they are the modification of the previously existing antibiotics. So Understanding LRTI and pathogens, you have 4 different types: community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, and aspiration pneumonia. And if you are practicing in India, TB is, of course, you have to keep it in one of the differential diagnosis in all the pneumonias, because you never know from where the TB bacteria will come, and it crashes the immune response, and the patient develops reactivation of tuberculosis in a pre-existing cavity on a pre-existing focus of infection. Because we all know that majority of us, at least 1/3 of the Indian population, is harboring TB bacteria in some or the other way. So 1/3 of our population, like if our population is 1.4 crore, so approximately 140 crore, so around 40 crore means 400 million of us are still carrying the TB bacteria. And if we develop complicated pneumonias and our immunity goes down, any time the TB bacteria can reactivate and can take a lethal turn. So we all know common symptoms like fever, cough, breathlessness, tachypnea. In severe cases, you can have reduced oxygen saturation and tachycardia and all those signs of sepsis and respiratory failure, to name few. So basically, if we talk about the spectrum of the lower respiratory infection, so ranging from bronchitis to bronchiolitis to pneumonia, and then various spectrum of the pneumonia, as we have already discussed. So now what is the challenge? Challenge is basically a diagnosis. So what do we have at present in our armamentarium to diagnose pneumonia? So we only find what we are looking for. Means we know that this person can have a bacterial infection. So we anticipate that according to the symptoms, according to the clinical profile of the patient, according to the presentation of the patient, comorbidities, and then we take a sample, either we take a sputum or bowel, whatever. We send to our microbiology and we ask them, we are suspecting this infection, kindly look for that. So we only know what we are looking for. We only target, because we always send a targeted test for that. What we are not looking for, something could be hidden, like patient can be having simultaneously 2 different type of infection, which we are not looking for at the moment. So that's very important that we develop and design a test which could detect much more than what we are trying to look for, so that we can preempt and treat the patient accordingly and prevent the patient from developing future complications. So different battles, we have almost the same arsenals. We have microbiological tests, we have culture-based tests, and we have now certain PCR-based tests. But what more than that? Nothing more than that. So let us change our thought process, our thinking, from hypothesis intense to hypothesis free. So let me explain you a bit about what do you mean by hypothesis intense to hypothesis free. It means that whatever research we are doing till now, what we are doing, we are formulating a hypothesis that this is a research question, and we are going to focus on that, so that our result, whatever the result comes, it is according to what we are anticipating. Whereas hypothesis free means we are utilizing certain tools, like newer tools, like we are utilizing bioinformatic tools, so as to find out something which is hidden inside, which we still don't know, or which is still elusive for us. So with this, I bring to you a solution with NGS. Can we solve and can we tackle all these questions with the help of a test or a new modality, which is NGS, or a next genome sequencing? We all know about this terminology, which is called next genome sequencing, from our experience with cancer diagnosis or cancer genomic study. Is NGS the solution which can lead us to a early diagnosis? So we will try to explore this from subsequent slides and from subsequent discussion. So what does this NGS does? As the name implies, it's a genome sequencing. What do? You take the sample, you process the sample in a specialized equipment, which is actually a dongle, which is a small dongle which can be fitted into a computer, and this is actually called a bio Oxford nanopore technology, which can read the sequence. What sequence? It reads the sequence. You know that for bacteria it is 16S ribosomal RNA, and for the fungi it is called ITR. So it can read the sequence and tell you which bacteria or which fungi we are dealing with. And this technology has evolved over the last 5 years. So first generation was by Maxim and Gilbert. Then it was a second generation by Torrent Illumina. And now we have a third generation sequencer, which is called a Oxford Nanopore sequencer. We will discuss in detail about this. So now NGS is gaining ground in infectious diseases globally. And we have enough data, ample data from various studies from in reputed journals. As you can see, that this technology is gaining grounds for early quick diagnosis and effective diagnosis, especially pneumonia and lower respiratory infection. Metagenomics next generation sequencing test takes the stage in diagnosis of lower respiratory tract infection because it is effective, it diagnoses rapidly and with less errors. So this is the team. I think Dr. Koyel will introduce about the team and all. So it is now recognized globally. So now what we are leading through, we are leading from intuitive medicine from to empirical medicine to precision medicine. So now we are heading towards, we all know that we are sitting in the time of evidence based medicine. So we are now heading towards precision medicine because we need to understand the pathophysiology of the disease. Exact diagnosis has to be made and early diagnosis has to be made. So understand the pathophysiology, make exact diagnosis and early diagnosis so that you alter the natural history of the disease and optimize the cure rate and prevent the complications. So this is the setup which I need to discuss with you in a bit in a bit short. So what you do, you take a sample, and the sample can be anything. We will discuss about this. And then on the right hand side you see that this is a computer setup where you can put a sequencer. This is the sequencer, as you can see here, and this is called an adapter, fungal adapter. This is also called a minion sequencer. What it does, you know that DNA is a negatively charged particle, and this also creates a negative charge. And what it does, it actually detects the double strand DNA of the bacteria through the adapter, through this nanopore, helps to detect the negatively charged base particle of the DNA. Why it is detected? Because it creates an electrical disturbance to the existing flux across this nanopore. And this electrical signal or electrical disturbance squirrel, which is called, is captured and is converted into a recordable signal, which is then translated into the base pair by this software. And what do you detect? You detect the 16S ribosomal RNA of the bacteria as well as the virus, and the ITR, which is called intensified repeat sequence in case of fungi. And you can correctly identify with least amount of error, and at the same time 9 bacterial genome resistance gene can also be identified in a single go. So this test is directly from the sample. You don't need to, like in case of culture, you need a medium. It has to go into the medium, then it grows into the medium. Lot of contamination issues can be there. Time lag could be there. And here the time taken is only around 8 to 12 hours. But overall collection of sample, transportation of sample, so all all these logistical issues are there. So it is calculated as total turnaround time, that is TAT, is around 24 hours. So sample collection, DNA extraction, pre-sequencing preparation, sequencing, data analysis, and report generation. Everything is automated, which is done by a bioinformatic tool, and everything takes 24 hours at the max for complete reporting in this scenario. So your go-to test for all types of infection, not only respiratory sample, you can test CSF, you can test body fluid aspirate, you can test peritoneal fluid, bloodstream infections, pus, urine, and even the eye secretions can be tested. So across all the sort of medical and surgical specialties, this test can be used. So for a BAL, like we are doing BAL, 4 ml of sample is required to be collected in a sterile container. So it's a culture-free test. Report can be given within 24 hours. Reliably detects co-infection, as we were discussing in the previous slide. As you can see, in a single sample, it can detect almost all the organisms. So our experience with NGS has been pretty good. For the last 6 months, we have been testing a lot of samples. Even Mycobacterium tuberculosis can be detected as a co-infection. And I'll just show you certain case studies which we have done in our hospital, most of them in the bowel fluid. So this was the case one. This patient was admitted in the month of June with a history of fever brought from other hospital. And we sent a bowel sample, and within a span of time, we found the culprit infection, and it was a true pathogen. It was a coronavirus. It was a viral infection. And this patient also had gram-positive cocci, which came out to be a streptococcus pneumoniae. So this was the second patient. Again, this patient came with a community-acquired pneumonia, sick patient in ICU. Bronchoscopic lavage was sent, and within no time, we got a report of streptococcus pneumoniae, and we could treat the patient effectively. Third patient, again a bowel fluid. This patient again came with ARDS, and we sent the bronchoalveolar lavage, and we could find influenza A virus infection, which is H1N1, and along with that, we could detect Klebsiella pneumoniae. So you see, it's so easy for us, and we don't have to wait for a long time for the culture reports. So dual infection treated effectively, discharged in a proper time, and the outcome was pretty good. So again, a third patient where we were not anticipating tuberculosis, we sent the bowel fluid for pneumonias, and surprisingly, we found Mycobacterium tuberculosis, and now along with that, we found gram-negative anaerobic bacteria. Case 5, again a bowel fluid, we found Staph aureus as a true pathogen, and along with that, we found Veillonella, which is a gram-negative anaerobic bacteria, and we treated the patient effectively, and patient got discharged. Sixth patient, again, a bowel fluid was sent, and you can see we found both Candida and Veillonella and Prevotella in a simple sample, and the patient was treated effectively and discharged. Seventh case, again a bowel fluid. Again, this patient was diagnosed with Streptococcus pneumoniae and coronavirus. So eighth case, again a bowel fluid was sent, an opportunistic gram-positive anaerobic bacteria was diagnosed in this patient as gram-positive aerobic cocci was found, and it was a Staph aureus. Again, a ninth case, this patient was a case of ILD. We did a bronchoscopy as well as transbronchial lung biopsy. Surprisingly, we found herpes simplex virus in this patient, probably as a opportunistic infection, and we treated this patient. Never anticipated to find herpes simplex, and we found herpes simplex, which is very, very rare to find in bowel sample, and we treated the patient, and the patient is doing pretty well. Later on, the patient was also diagnosed with vasculitis, that is MPO1 vasculitis. So we know that vasculitis is an immunosuppressive state, and patients can develop opportunistic infections. Again, this last case, we were anticipating bacterial infection, and we found it was a diabetic patient, immunocompromised. We were anticipating fungal infection, and we found Candida tropicalis in this patient. And if you send a fungal culture, you need at least 2 to 3 weeks for the fungus to grow on a fungal culture. And again, if you want to differentiate the species, you need another 1 week. So to isolate fungus, you need at least 3 to 4 weeks to correctly identify and typify the fungus. And with this, you can get to know within a span of 20, within a minute time of 24 hours what you are dealing with, and accordingly you can treat the patient. So this is all about the advantages, the importance, the relevance, and in current times, how it is improving our diagnostic, and how this technology can be used for the benefit of our patients, especially in the setting of critical care and the ICU, and especially in the sick patients like those who are coming with pneumonias, in immunocompromised patients, where you cannot wait for a long time, and in a patient who has undergone a lung transplant, or a patient on a chemotherapy, where you need a definitive diagnosis within no time, or within a 24 hours time, so that you can treat your patients in an effective and smooth way with a better outcome. So thank you for your patience hearing. I think now the forum can be open for questions and answer for the discussions.
Uh, Thank you, Dr. Shamim. Thank you so much for detailed and an insightful talk about NGS and these fantastic case studies that you have shared with us today. With this, I would just like to add two sentences before we open to Q&A, that infection NGS in patients with lower respiratory tract infections have and the results that we have seen are very encouraging. So like unlike conventional cultures which were often which took several days to detect a pathogen, maybe sometimes it was missed, so these has been overcome. So the limitations of the conventional diagnostic tests are overcome, and in 1,000+ samples, we have seen that infection NGS has helped us to identify the causative organism within a very shorter period of time, and with much higher sensitivity, even when there were situations when culture was negative. And with this, I would like to say that NGS is not is NGS is actually bringing the clinicians from a chaos mindset to a clarity mindset. So we can say it brings clarity in the chaos. With this, I would like to end today's presentation, and thank Dr. Shamim Akhtar for such an engaging talk, and thank you everyone for being such a wonderful audience.